everyone. This is Beth Lubenthal again, Nursing 380, and we are moving on to our next voiceover lectures. I do want to mention or add a few notes about Chapter 3. Chapter 3 deals with concepts of psychobiology. This actually, you all should review and know the structure and the function of the brain. You also should review and know implications for nursing of the items that I have listed down there. I am not going to be testing you on these, but I want to make sure that you review that, or if there is a need as we get along in the semester for you to review some of these structures and functions, that you know that it's in Chapter 3. Chapter 4, I also want to add a note about, talks about psychopharmacology, and we will be using this chapter throughout the semester. So when we talk about, say, schizophrenia, I will have segments of Chapter 4 that deals with antipsychotics that I'll be referring you back to, and have page numbers and information that you'll be required to know out of Chapter 4. But I'm not going to do Chapter 4 early in the semester and require you to know all the meds before we even get into the disorders. Okay? So that brings us to Chapter 5, the ethical and legal issues in mental health nursing. So we all know that ethics is the philosophical ideals of right and wrong. All right, and I know that if you haven't taken an ethics course or a biomedical ethics course, you will be, but that you have talked about ethics in your other classes. And so nurses have a duty to practice ethically and morally. All right, so all healthcare professionals do, and definitely nursing is part of that. And ethics is a very important fundamental part of nursing. All nurses should have respect for their patients, protect the patient's rights, so therefore we need to know what the patient's rights are, and maintain their dignity. Like in all areas of nursing, mental health nursing, we definitely come across ethical dilemmas at different times during our practice. So it's very important that we are aware of what those are before we actually get into those. Many of the ethical dilemmas have to do with a patient's consent, confidentiality, therapeutic boundaries. As nurses and as psychiatric nurses, we do have help when we face ethical issues or ethical dilemmas. First of all, the ANA has a code of ethics, which you probably have looked at first semester. But page 87 in your book has a review of that code of ethics, so I would like you to look at that again. The American Psychiatric Nurses Association, which is a professional organization for psychiatric nursing, has many documents and has many guidelines for dealing with ethical dilemmas. The APNA has also been very influential in helping the ANA write the scopes and standards of practice for the psychiatric mental health nursing. So those are areas that we can turn to when we to help us with guidelines or to help us with ethical dilemmas. So three ethical issues that I want to talk about first of all are listed here on this slide. First of all, right to treatment. This basically is saying that anyone who is admitted to a hospital treatment center has the right to appropriate treatment. Okay, not just any treatment, but it has to be appropriate, evidence-based, has shown to work in the past. A person cannot just be admitted to a hospital and held and not be treated, or put into a hospital or institution and just housed, if you will. They have to have they have the right to appropriate treatment. And this has also led into many other organizations who have actually have standards for hospitalized patients, and many of those standards are posted in the actual nursing units and in hospitals, so patients know what their rights are. Patient also has a right to refuse treatment. Okay, so it might be, and we know this in healthcare in general, and psychiatric patients or psychiatric clients are exactly the same. They have the right to refuse any type of procedure. They have the right to refuse medications. Okay, but sometimes we can get into a dilemma when we see that a patient is in immediate need of medication or immediate need of a procedure because they are a harm to themselves or to other people. Okay, so this would be an exception to that. So if this would be the case, state statutes have said that if a patient is a danger to themselves or to somebody else, that we can withhold that right. And it might be that we need to go before a court to get an order for this, but that we can withhold their right to refusing treatment or to refusing medication. Okay, the next one, clients or patients have the right to the least restrictive environment, to be treated in the least restrictive environment. So this is basically an example that if a client can be treated in a community, say living at home or living in a halfway house or supervised apartments, then that is the least restrictive environment for them. Or if a patient actually does need to be in a hospital, need to be admitted to the hospital, can they be treated in a unlocked unit versus a locked unit? What is the least restrictive environment that they can be in? So what we're really looking at is providing the appropriate treatment to the client with the maximum freedom. And we want to provide the least amount of limits to provide for their safety. If a patient does become agitated and is starting to be a danger to themselves or to others, we must do the least restrictive interventions first, and then we can gradually move up to more restrictive interventions. So for example, like I said, if somebody was becoming very agitated, we would first start with verbal interventions, and those verbal interventions might be sitting down and talking with them about the situation. It might be, helping them sit down for a timeout. It might be helping them with relaxation exercises or helping them to talk about, their anxiety. Maybe do some anxiety exercises. If those verbal interventions did not work, the next intervention would be medication that might sedate them or might help them help their dangerous thoughts or their threatening behavior, and that would be seen as a more restrictive than verbal interventions. And if those medications that were given did not work, then the next restrictive intervention would be a physical restraint, which might be either actual physical restraints or some type of seclusion room. It's important to know that restraints should never be used as a punishment or for the convenience of the staff. Okay. And like I said, other measures, least restrictive measures, should be used first. And then we should always, as nurses, then make sure that we are documenting our interventions, but always documenting that we are using the least restrictive interventions first. The Joint Commission has issued standards regarding seclusion restraint, and those are in your book on page 98. There's 5 of those standards that I want you to look at. The first one there says seclusion or restraint is discontinued as soon as possible, regardless of when the order is scheduled to expire. And unless your state is more restrictive, a minimum, a person orders for restraint or seclusion must be renewed every 4 hours for adults and then every 2 hours for adolescents and pediatrics. Orders may be renewed according to these for 24 hours. An in-person evaluation has to be done by a physician or a provider within 1 hour of initiating the restraint or seclusion. And then staff, and then it goes on with 4 and 5, but staff must also be trained in seclusion and in restraints. Okay, let's go on to the next slide. Legal considerations. Most of these are legal issues or considerations in psychiatric mental health nursing. The first one we come upon is confidentiality and right to privacy. So we know confidentiality and right to privacy. We are all familiar with HIPAA. And we know that, some of these privacy statements vary from state to state, but HIPAA is universal. The exception to the confidentiality and right to privacy in mental health is a mental health professional has the duty to warn if an individual is threatened. So for example, if I'm counseling somebody and my client has made a threat against another person in the community, I do have a duty to warn that individual. All right, so that would be the exception when there's a duty to warn. This there are it varies from state to state whether nursing should be involved in this, but nurses should be letting the treatment team know all of the information that we get from our patients. Okay, the nurse is a part of an interdisciplinary team that contributes and collaborates on the patient's care, so all information that we are gathering from patient should be included in this team meeting. So we cannot guarantee a patient that everything that they tell us is confidential. So we cannot keep anything 100% confidential. And when we get into clinical, we'll talk a little bit more about this. Another exception would be if there is suspected child or elder abuse. We have a duty to notify appropriate services about suspected or child or elder abuse. The next one I have on there is informed consent, and informed consent preserves and protects the individual's autonomy of what will or will not be done to their own body. Okay, so that has to do with medications and procedures. They do have a right to have the procedure, the medication explained to them. They have the right to have, medications or side effects, dangers, all of that sort of thing been given to them and informed. The next one on here is restraint and seclusion. I already talked a little bit about that, but more of a legal consideration. Individuals, patients, clients, they have a right to freedom except in an emergency, and I already talked about that, and that emergency would be when they are in a danger to themselves or to others. We know that restraint and seclusion can cause trauma and mistrust with our clients, so we don't want to do that except if it's an emergency. And there is a huge movement, actually a successful movement, to start looking at restraints in hospitals and trying to use them as minimally as possible. And there are many hospitals in the country now that are restraint-free, that don't use restraints at all. But again, we need to be very careful when we are using restraints and seclusions. And as I mentioned, that process on page 98 in the Joint Commission guidelines, I want you to look at those and to know those 5 guidelines. Now, legal considerations with hospitalization. Courts and legal rights play a very important role in how we protect human rights. And those, especially when somebody is hospitalized. And those laws, the courts, the legal rights vary from state to state, so we must be aware of state laws that we practice in and statutes. A patient can be admitted, or a client can be admitted in a voluntary admission. This is where a patient or client signs a voluntary consent form, and they have a right to demand and obtain release. Any voluntary patient can leave whenever they would like. Okay. Now, if the doctor or provider does not feel like they should be discharged, in Iowa, as in many states, we have against medical advice form that that a physician or a provider can request to be signed. Okay. We also have involuntary commitment. Again, involuntary commitment of an individual varies from state to state. When we involuntary commit somebody, or when we force somebody to come into the hospital, okay, a commitment, we are taking away the person's right to their freedom. So we can only do this if they are a danger to themselves or to other individuals, or if they are unable to take care of themselves. So if their basic personal needs are not met, we many times call this gravely disabled, and that would also be a reason. Okay, they're not able to take care of themselves, they're a danger to themselves, that they can be involuntary committed. There's a few different ways that a patient can be involuntary committed. The first is an emergency. Oops, I'm on the wrong slide. Let me switch to the next slide. Then the ways that they can be involuntary committed. First one, emergency or 48-hour hold. This is where a petition must be filed within 48 hours or in 2 business days. So let's talk about this. Emergency or 48-hour hold. This means that we are holding a patient against their will, all right? And once we, in order to do this, we have to have a judge give us permission to do this. So we have to have an order by a judge in order to hold somebody on a 48-hour hold. So for example, if somebody who's in the emergency room, maybe they are very suicidal, but they don't want to stay, they don't want to be admitted, and they want to leave, and they're demanding to leave. We can hold them against their will, but in order to do that, we have to call the judge who is on call, okay, and explain the situation to them, and if that judge who's on call deems that the patient is a danger to themselves or to somebody else, we can hold them against their will. But within 48 hours, somebody, either a family member or physician, has to go to the courthouse and file a petition for commitment within 48 hours. And if that is not done within that 48 hours or the 2 business days, then the patient is free to go. Okay. Another way that we can have involuntary commitment is petition for commitment. And petition for commitment has to be filed by 2 persons. And what happens there is that if we feel that somebody is a danger to themselves or somebody else, 2 people, it might be family members, can go down to the courthouse and file a petition for commitment. And within that paperwork, it explains why they feel that the patient needs to be admitted against their will. And then once that petition for commitment is filed, then the patient can be brought in by police or by sheriff to be admitted to the hospital. Now, once they are admitted to the hospital is required to have a hearing within 72 hours or 3 business days, within 72 hours with attorney and a judge, and then the judge decides if the patient should be committed after hearing, from the people who made the petition, and then also from the patient or the patient's attorney. The judge decides if the patient should be committed or that the petition should be discontinued. Once the patient is committed, the commitment will last until the doctor or the provider feels treatment is finished and discharges the patient. We also have involuntary outpatient commitment. An involuntary outpatient commitment a lot of times is referred to as conditional commitment. And this is where there are certain conditions that must be made or must be met in order for them to stay as an outpatient. So, for example, the involuntary outpatient commitment is conditional on the patient coming in every 2 weeks for their doctor's appointments. It's also conditional on the patient receiving their IM shots once a month. So that would be one example. Okay, so they can stay on an outpatient if they meet these conditions. Okay, and then they are able to go back out into the community, either live at home or live in a halfway house, that sort of thing, but they are an involuntary outpatient commitment.